السلام عليكم ورحمة الله وبركاته.
وعليكم
شكرا
السلام.
جزيلا دكتور فاضل على التقديم. Thank you very much for the introduction. Uh, my talk about the diabetic Charcot ankle is an overview about the pathology and decision making regarding the medical and the surgical treatment. As my colleagues have illustrated before, Charcot neuroarthropathy is a progressive non-infectious destructive disease of bone and joints in persons with sensory neuropathy. And there are multiple theories about the etiology of the Charcot neuroarthropathy, including the peripheral sensory loss, the autonomic neuroarthropathy, which leads to increased blood flow, trauma, which is an important precipitating factor. Although most patients do not remember any injury, the bone metabolism, where the increase of the osteoblastic and osteoclastic activities lead to bone destruction, excessive bone destruction. And recently combined the theory of pathogenesis of the Charcot neuroarthropathy, combining the automatic, neurotraumatic, and the neurovascular theories, where there is sensory motor neuropathy and autonomic neuroarthropathy and precipitated by trauma, leading to dissolution of the joints of the ankle and the foot. The incidence of neuroarthropathy in general 0.1 to 0.5%, but in diabetics, it's up to 3 to 5% of the patients. And it's bilateral about 30% of patients. The clinical presentation, it presents in three phases: the acute or active phase, the dissolution phase, and the chronic or resolution phase. The acute phase, where there is the foot and the ankle are red, warm, and swollen, resembling acute infection or gouty arthritis, which have to be excluded in the or included in the differential diagnosis of early cases. There is no pain or only some discomfort. Then early, there is no deformity, and the X-rays may look normal. So there must be a high index of suspicion for early diagnosis of cases of early Charcot in the acute stage. Then the dissolution phase, followed by the chronic or the inactive phase, where all local inflammatory signs will regress, and there is the associated extremity redness subsides, and the difference in skin temperature between the 2 feet diminish, and the deformities become more progressive. The investigations include X-rays. In the beginning, they may look normal. No significant findings will be found. And later on, there is bone and joint destruction with fragmentation, joint dislocations. Very important, the routine investigations, including the markers for the infection like ESR, CRP, the A1C hemoglobin, and the liver and kidney functions are important. Bone scan may be important in early diagnosis. Leukocyte label scan can differentiate from osteomyelitis. MRI
السلام عليكم.
examination is
ازيك يا
important
يوسف؟
where there
عامل
is
ايه؟
the treatment of Charcot neuroarthropathy includes immobilization, which is very important part of the treatment, pharmacological treatment, and surgical treatment. Immobilization for at least 16 weeks is very important, including the wrist, the half shoes, the total contact cast is a gold standard, or a pneumatic walking brace or air cast is very important in the early phases of Charcot neuroarthropathy. The pharmacological treatment is an integral part of the treatment of Charcot disease. The bisphosphonates to decrease the osteoclastic activity and decrease the bone turnover, calcitonin, vitamin D and B complex, vasodilator. Very essential is the control of diabetes mellitus. And now to the surgical part of treatment. It's indicated when there is non-reducible or non-correctable deformity with increased plantar pressure resulting in a non-healing wound or grossly unstable foot or ankle that's not amenable to brace treatment. The goal of treatment, as Dr. Barakat mentioned, it should the plantigrade stable foot. The surgical treatment is contraindicated if there is uncontrolled diabetes. We have to optimize your patient before surgical interference. There is a relative contraindication for surgical interference during the acute phase for fear of acute infection. The surgical treatment is to correct deformity, achieve a stable limb. These techniques include mainly arthrodesis, excision of bone exostosis, reconstruction of defects, and Achilles tendon lengthening, which is short in most cases. Very important to note during surgery, the avoid creation of subcutaneous of thin skin flaps. There must be a full thickness skin incisions to ensure the vascularity of the skin flaps, gentle handling of the soft tissues, the use of osteotomes rather than electric saw to avoid thermal necrosis. The use of bone grafting is essential to fill the bone voids, even synthetic bone graft. The secure fixation or rigid fixation is essential. The adjunctive use of anti-resorptive medication in the acute phase is like bisphosphonates and calcitonin is very important. Prolonged post-operative immobilization is important. The methods of fixation include internal fixation, either screws or intramedullary nails, external fixation by Elizarov fixator, or hybrid fixation combination of both internal and external. Internal fixation using the compression or lag screws is very important, and the configuration of the screws can provide a stable ankle fusion with preservation of the subtalar joint if it is mobile. However, this cannot be used if there is osteoporosis because there is loss of fixation. On the other hand, the use of ankle fusion nail, as demonstrated by Dr. Barakat in his talk, is very important. It's less invasive, provides a stable construct, and allows early mobilization, and can be inserted with arthroscopic preparation of the ankle joint. We have done this, or in senile patients and less demanding patients, we can insert the nail percutaneously without preparation of the ankle joint. And this is the result of the retrograde ankle fusion nail. It can be used also through a small incision from the hip without preparation of the ankle joint, like in this case, morbidly obese patient. We can see here the post-operative. However, we have to take care during the insertion of the nail, avoid re-injury of the plantar nerves. Also, avoid using the short nails, like in this case, because it can result in stress fracture at the tip of the nail. It's better to use longer nail. Also, avoid the medial entry of the nail because it can cut through the calcaneus, leading to failure of the implant. It's contraindicated if there is unhealthy heel pad, or if there is proximal tibial deformity, or there is inability to collinearly put the foot under the tibia. In cases of extreme bone loss like this, the salvage of cases with bone loss, infection, or osteoporosis is the use of the wires, only Elizarov external fixator, to provide to result in a stiff, stable fibrous fusion in a good alignment. So we have the showable foot, which is stable and plantigrade. It's not necessarily bone fusion. It can be a stiff fibrous union, and it is reserved for the most difficult cases. However, certain problems can occur with the use of the Elizarov or external fixtures in general, like pin tract infection or patient intolerance to the external fixture. If the patient is senile or morbidly obese, it's very difficult to tolerate such a device, or refracture after fixator removal. That's why we use the hybrid fixation using lag or compression screws combined with the Elizarov external fixture. So the external fixture allows compression and protection of the weak interfragmentary screws, and thus after removal of the fixture, the screws are left as a permanent splint to prevent refracture. So the choice of fixation method depends on the skin condition, if there is infection or not, if there is the amount of bone loss, the presence of osteoporosis, and the patient's convenience, and the surgeon's expertise. This is the ugly face of internal fixation of diabetic ankle fracture. So if there is a patient with diabetic patient with ankle fracture, we have to evaluate the condition, if the blood glucose level controlled or not, if there is peripheral sensory loss or not, the fracture time is acutely presenting or late presenting. So internal fixation should be practiced only in favorable condition. Otherwise, we have to go for the ankle fusion, immediate ankle fusion. We can see, so never underestimate a diabetic ankle fracture. If you wait in a splint, like in this case, you can end up with an open infected ankle fracture. The treatment of which is only, like in this case, we did excision of the exposed distal part of the tibia and upper part of the articular surface of the talus with acute shortening to allow closure of the skin defect and the application of Elizarov external fixture, which has to be super rigid device. In this case, the fixator was only wires Elizarov external fixator, which was not stiff enough. These patients, we have to be cautious because these patients have no sensory sensation in their feet and may be living on their own, and they have to ambulate in their house to go to the bathroom and help themselves. So they put weight on the device, so the loss of sensation may lead to unprotected weight bearing and the breakage of the wires in this, such like in this case. So the take-home message, the treatment of Charcot neuropathy is a team approach that indulged in not only the orthopedic surgeon, but the internist, the psychiatrist, and the neurologist, all are indulged in the treatment of Charcot patients. There must be a high degree of suspicion to diagnose acute Charcot arthropathy to avoid deformity. Any ankle trauma in a diabetic patient should be considered as Charcot ankle. A high risk categorization of such patients. Immobilization is very important. Pharmacological treatment should not be ignored. Customized footwear is used. Surgery with special cushions. Thank you.